Ormancı is from Positive Living Association, with which we have been working together for many years. So Canberk Ormancı is going to provide us with the perspective of the impacted individuals and the association. And also from the migrant perspective, Hatice Hilal Varan will be speaking. She is from Istanbul Service Unit of Key Refugee Groups Projects. And during these speeches, you may want to ask questions. We will have a Q&A box where we will get your questions. At the end of the panel, we will try our best in order to answer all your questions. I wish you good luck, and I would like to give the floor to our first speaker, Mr. Hassan Muhtashami. He's also our host today. He's from UN Population Fund, and the floor is yours for the opening remarks. The floor is yours.
Thank you so very much, Professor Serhat. I appreciate that. Let me first recognize the distinguished participants in this panel and welcome everybody who is online and listening to this presentations. I recognize and appreciate the participation and blessing of this function by Professor Serhat and Professor Selma. I really appreciate taking the time and being with us today and enriching the discussion with your academic and technical insights and presentations. I also recognize our partners, Mr. Canberk and Hatice Hanım, that they are with us today and presenting their perspective on the issue in Turkey. And welcome everybody who is online and listening to this. I hope this will be a useful and action addressing HIV globally. I know that Turkey is the host of the largest number of refugees in the world. Everybody should appreciate and recognize that government of Turkey and people of Turkey has generously hosted quite a significant number of refugees for several years and shared their resources, services, and everything with them. I think international community has also the responsibility to support Turkish government and people in Turkey in their efforts to provide services and hosting the refugees. Among the refugees, there are certain groups that we think they may be considered as part of those groups that may be left behind. HIV positive refugees, or sex workers, or those who have left behind in terms of our other elements like gender-based violence, or those who are subject to domestic violence or gender-based violence. So elements of the refugee communities that may be subject to some other hardship, in addition to being displaced, in addition to being forced out of their home and home country. So for us, it's important to address those elements of refugees as well. And hence our project, which is now supported by European humanitarian aid, EU humanitarian aid, and then we have 7 centers. We have outstanding partners for implementation of this project, Red Umbrella and HIV Positive Association. I'm making the mistake about the name. It's Positive Living Association. So these outstanding partners have helped us to reach out to, through these 7 centers we have, to a good number of refugees that can be categorized as the key refugee groups for us and need special attention, special programs, special services within the context of our program. I would like to end this by seriously wishing that this webinar can be helpful in re-energizing and refocusing our attention on the HIV issue in Turkey. I used to say in mid 2000 that we have forgotten that family planning is a priority, and all our attention is on HIV and AIDS. I was then serving in Africa. As if family planning is a past invite for family planning. Still very much in front of the all infection diseases, and we should take a good look at it. As Professor mentioned, just last year, 1.5 million more people were infected. It's not a finished agenda. It's not a controlled infectious disease globally, and we need to still have a close eye and close look at the HIV pandemic. Professor Selma, thank you so very much.
Thank you very much, Mr. Muhtashami, for covering this issue very extensively and comprehensively. Distinguished guests, without losing any further time, I'd like to move on with my presentation. I'll be talking about HIV briefly and the situation of HIV in Turkey and the combat that we have against the HIV in Turkey I will be covering. At the end of the 1970s, in United States of America, a disease occurred among the gay guys, especially in people with immune deficiencies, including people with in people with pneumocystic carinae, and people understood that this was a new disease, but they could not understand the cause of the disease. So they tried to identify the disease, acquired immune deficiency syndrome. They defined this disease. So this is something which is bringing about immune deficiency. At the beginning, people in the USA did not focus on this situation very much because it only affected a couple of cases, but then it's disseminated, it spread among the women, among the children as well, and it attracted a lot of attention. And a lot of famous people then turned out to be living with HIV, including Freddie Mercury and Rock Hudson. So the topic attracted more and more attention in time. As you can see, in 1981, the diagnosis of Kaposi sarcoma and pneumocystis carinae pneumonia in young men in the United States came about. And in 1982, the naming of the disease as AIDS came about. Then isolation of HIV-1 in 83. And in 84, development of antibody tests came about. And then between 1981 to 1987, then came the first FDA-approved medicine for this disease, the drug for this situation. So from 1981 to 1987, the first treatment was found for AIDS, I can say. We can compare it to pox disease, for example. Pox was eradicated thanks to the discovery of the vaccine, but it took a longer time for us to find the treatment and vaccine for the pox, including tuberculosis. We are still combating the tuberculosis cases, and malaria. Very recently, they discovered the vaccine for malaria, but it is still a problem, TB included. They are still problems affecting the whole world. Well, in AIDS, we were quite successful in finding the treatment, but the drug as well, but still it has not been eradicated from the world. Still, we need to do a lot. We have good medicines, we have good drugs, and AIDS now is not shortening the expected life expectancy of the people. I believe in the next years, in near future, we will be having a lot of more promising results for fighting the AIDS. And a lot of scientific research was made on AIDS and HIV, and it was imagined that it was considered that AIDS was transferred from a monkey from monkey to the humans, but still, this is the mostly agreeable argument that we have today. It is an RNA virus causing all of this HIV structure. RNA is sticking to certain structures, as you can see here, and it is carrying the RNA inside the structure. And once this virus goes into the body, it somehow infects all the cells of the body and makes the person sick. And I always use this slide, although it is quite an old one. This is the transmission of HIV. It is generally transmitted because of uncontrolled sexual intercourse. I have to underline the word uncontrolled. Intercourse between men and women, it doesn't matter. Every kind of uncontrolled sexual intercourse may lead to the transmission of HIV. And it is also transmitted because of the transfusion of blood, infected blood and blood products and other body components. But there are special procedures, medical procedures, to decrease the transmission of HIV through the infected blood and blood products. And the thing is, this is still a reality that it may be transmitted from the transfusion of blood, especially if you're using injectors, syringes between two people, one of whom may be HIV infected. We may be talking about the possibility of transmission of HIV. We believe that there has been a lot of progress in preventing the transmission of this HIV because of the use of syringes and injectors, but still we have these cases. And we have mother-to-child transmission of HIV as well. Today, thanks to the medicines and drugs that we are using extensively, we reduce the rate of transmission of HIV between mother and child. We have special preventive measures and drugs that we use in order to prevent the transmission of HIV from mother to child. It seems that we somehow control the transmission between mother to child, but still uncontrolled sexual intercourse is the biggest problem when it comes to transmission of HIV. On the right-hand side of the slide is that much important because we need to be aware of the ways which do not lead to the transmission. For example, eye drops, eye tears, saliva, normal social contact, or insect vectors do not lead to the transmission of HIV. There is no evidence that insect vectors, social contact, saliva, tears lead to the transmission of HIV. There is no such scientific evidence, I have to admit once again. This is important to know because we need to prevent stigmatization and we need to prevent discrimination of HIV positive people. This is why we need to know what does not lead to the transmission of HIV, including eye tears, etc., social contact. This virus goes into each and every cell of the body. It can infect all the cells of the body, but it generally infects the immune system of the people, of the humans. We have a lot of cells in the immune system that we have. Nowadays, we are more familiar with the immune system because of the coronavirus. We have white cells and we also lymphocytes, B type, C type lymphocytes, but lymphocytes, which are white cells, actually blood cells, are like the chef of the orchestrate when it comes to the cellular system. It manages the whole cells, the whole cellular system, and HIV especially enters the lymphocytes and it multiplies in the lymphocytes and it kills the lymphocytes. This is a real photograph, by the way. This is the real HIV virus in the lymphocytes in the body of a person. Once the virus goes into the body, enters the body in 2 or 3 weeks, first of all, there is this acute viral infection-like situation, clinical picture occurring in the body. Generally, people cannot understand this may be related to HIV, but again, awareness has been raised in Turkey and around other countries that it may look like something else, as a flu or something in the first acute phase of the disease. Then it starts to kill the C4D cells of the body, and then what happens is CD4 cells go down in number because of the infection with HIV. Every year, annually, there is this reduction in the CD4 cells in the body because of the infection with the HIV. In time, this is called the asymptomatic process of the disease. You cannot see any signs of the disease, any findings of the disease in the last 8 to 10 years, but still reduction of CD4 cells continues to happen in the body. So if the person is tested against HIV, there is high probability that the disease is diagnosed. But if the person is not getting tested and continues the risky behaviors, then the person may go undiagnosed and may in the end in AIDS, in which we cannot talk about the presence of immune system at all. And we have these opportunistic cells which may lead to cancer and others. I don't have the time to go into this today, but what is good nowadays is we have high rates of early diagnosis, and we have good drugs and medicines today. If a person already reached the stage of AIDS, then the person may face death in 2 or 3 years if not managed properly. But today, thanks to the early diagnosis, and thanks to the medicines and drugs, we can make people survive. They can make a normal living without low life expectancy. This is the occurrence of opportunistic infections in relation to the declining of CD4 plus cell count of the HIV positive parents. What we do is we measure the amount of virus load in the body, and then we try to measure the CD4 plus cell count in the body. I don't want to go into details, but the thing is, in the early stage of HIV, some frequent sinusitis, skin infections may occur in the person, loss of appetite, loss of weight, etc. And then as the CD4 cells go down, then thrush, mouth and tongue disease may occur, severe athlete's foot disease may occur, oral hairy leukoplakia may occur, and then AIDS-defining infections may occur in the last period, in the last stage of the disease, in line with the increasing load of the virus in the body. This is why we are trying to catch the patients in the early stage of the disease. I don't want to go into the details of the treatment, but please believe me when I say that in the past, we had patients who had to use 13 or 14 pieces of drugs a day. But today, people living with HIV can take only 1 tablet of pill and they can sustain a normal life. This is the development and advancement that we have today. And the drugs will lead to the reduction of the multiplication of the viral load in the blood, and the person can lead a normal life thanks to the intake of this 1 single tablet today. But if the person stops taking in the tablets, the disease may revive, may resurge again. Well, there is this tablet, which is also integrating 2 or 3 pills in 1 single body of tablets, but the person has to use this tablet for the whole life. If they stop using it, as I said previously, their disease may resurge again. But hopefully we will come to days in which we will eradicate this disease totally. From the beginning to the end, to today, Turkey has been fighting this disease. Back in 1985, when I was an infectious diseases expert, we started to see cases in Turkey. I remember my first cases of HIV. We diagnosed the cases back then and we managed them. We started to manage them. You know, there was this application of serological tests in 1987. Then the test became reimbursed in 1996 in Turkey. Then came the establishment of voluntary counseling and test centers in 2007. Then came the guidelines, diagnosis treatment guide was adopted in 2013, for example, in Turkey. And also the disease started to be monitored using some computer software, and strategic national plans were adopted as of 2016 in order to combat this disease in Turkey, similar to the efforts of the other countries, I can say. Well, notwithstanding all the efforts in Turkey, we cannot say that we eradicated this disease in Turkey. After the first diagnosis in the 1st of October 1985 until December 30, 2020, we had many cases. The number of cases can be seen in the middle of the screen at the moment. We do not know the exact number of cases for 2021, but this is the total number of cases until the end of 2020, a total of 28,421 people were diagnosed with HIV since the 1985 until the 2020 December. Well, and 1,974 people are diagnosed with AIDS because they could not be caught in the first stages of HIV actually, but a big majority of the people could get an early diagnosis and they could sustain a normal life. You can see the increase in the number of cases in time, but in 2020, there has been a drop in the number of cases of HIV. In 2019, the number of cases were almost 4,000, but in 2020, we had a reduction in the diagnostic capacity because of the pandemic. This is why it looks like we had lower number of cases in 2020, but this is not the case. People could not reach out to the hospitals. They could not be served by the healthcare system, and the diagnosis could not be properly made in the HIV. This is why we had decreasing number of cases in 2020. But nowadays, we can see, especially after the lifting of the quarantine, there is an increasing trend in the number of cases, and I believe this is also the case among the refugees. Normally, this bar for 2020 should have been longer. And in 2021, the numbers will be even higher, actually. The disease did not make a plateau, not yet. The disease is not having stable numbers of cases, not yet. The test opportunities are increasing. The treatments are more getting disseminated, but still the number of cases is not decreasing in Turkey. This is the case, and these are the yearly incidences between 2007 to 2020. It was almost 4 point something in 2019, and the numbers are not representative of the actual reality in 2020, I have to admit, because of coronavirus. But the thing is, special training programs are conducted as a result of the number of cases being documented. But the thing is, this is the distribution of cases by ways of transmission, and generally the way of the transmission is reported as unknown. This may be because people do not want to talk about how they may have gotten the disease in the first place, but we believe that 32% of the transmission happens because of heterosexual intercourse and followed by the homosexual sexual intercourse. And mother to baby transmission is relatively low when it comes to the other ways of transmission. And this is a distribution of HIV positive cases by age and then gender. And this is generally a disease afflicting sexually active people. This is why you can see the numbers are going down when it comes to the ages of 60 to 65 or something. The disease is generally happening in the sexually active ages. In Turkey, the cases were generally among the men, but today we can still see the disease is more frequent among the men today in Turkey. It may be more frequent, dominant among some women in certain countries, but this is not the case in Turkey. Well, this bar should be paid attention to, because the age group of 15 to 19 is also getting this disease in an increasing trend, we have to admit. Well, this is a distribution by age and gender, as I previously stated. The previous one, can I come back to the previous slide? This was the representation of the total numbers, and this is otherwise, let me read it. This is distribution by age and gender. We need to pay attention to the increasing number of cases among the people aged 15 and 19, 15 to 19. Well, this is the distribution by age and gender according to the years, you know. Especially as the years advance, we see that the disease is becoming more prevalent among the young people. And when we look at the age group, 0 to 15 years of age especially, you can see the total number of cases is 620 among the people aged 0 to 15. And after 2012, there has been an increase in the detection of the cases of young people, especially 0 to 18 years of age. So you can see the distribution of cases between ages of 0 to 18. And this is the distribution by age. So especially the ages of 15, 16, 17, 18 is having an increasing trend of detection of the disease, because sexuality might be beginning to happen in those years of age in Turkey too. So in this slide, you can see the distribution of HIV cases between the ages of 0 to 17, 18 by age and gender. These are the total cases, actually, including both girls and boys. As is the situation, the boys are having the disease more prevalently compared to their girl peers at the ages when the sexual activity starts. I cannot say why boys are having this disease more than the girls. I cannot make any comments about that. Maybe the other speakers will mention this topic later on. And this is the distribution of cases by the possible modes of transmission. Mother to infant transmission is here in purple, and 39% of the cases cannot be determined in terms of possible modes of transmission. Abuse of substance is not having a larger pie of the cake here. Actually, in Turkey, substance abuse is never one of the dominant ways of transmission, modes of transmission for HIV in Turkey, but still the number of cases which have been transmitted because of substance abuse is increasing in Turkey too. Turkey is a medium endemicity country when it comes to HIV. And HIV cases are increasing in number, especially among the young people in Turkey. This is why, let me mention what the globe is doing. What is the global approach to fight HIV? In line with the 2030 vision, 0 new HIV infection is the target, and 0 HIV-related deaths is another target, and 0 discrimination to remove the AIDS epidemic as a public health threat by 2030 through ensuring healthy lives and well-being at every age group. And there are a lot of measures to be adopted in order to achieve these targets. There is this 90 plus 90 target objective every country is trying to achieve. The first 90 is to diagnose at least 90% of the cases of HIV at national level. And at least 90% of these diagnosed cases should enter the healthcare system. And at least 90% of the cases should have 0% of viral load in the end of the treatment. This is the 90 objective, or a program that every country is trying to achieve globally. So 90 plus 90 methodology is also an approach Turkey is adhering to. As I previously stated, we have strategic plans for us to combat HIV and AIDS. And in line with the strategic plans, Turkey is announcing an HIV/AIDS control program every 5 years. 2019 to 2024 HIV/AIDS control program is also structured to improve the capacity of healthcare services, decrease the number of cases of HIV, and also to prevent discrimination and violation of privacy towards the patients. So these are some of the objectives laid down in the HIV/AIDS control programs of Turkey. And there are certain measures to achieve these objectives respectively. And the midterm evaluation shows that we could achieve we could complete 90% of the actions in the current 2019-2024 program, and we could not start doing 47% of the actions of the program at all. It means that we cannot call the meetings of this program. Ministry of Health cannot call the board meetings for this control program regularly because of COVID-19. And healthcare professionals are generally exerting their energy for the corona pandemic rather than the other issues. And this is the HIV/AIDS diagnosis and treatment guide that we have. In time, this guide has been updated in Turkey, and all the centers and healthcare facilities engaged with HIV cases, how to adhere to this diagnosis and treatment guide. It talks about when to do the testing, who should get the testing, what measures to be adopted for those people who turn out to be HIV positive as a result of testing, etc. Prenatal care is specifically attached great importance to in Turkey. This is why we have the prenatal care management guide in Turkey, which talks about the first observation, etc., and other measures to be taken in the prenatal care period, especially in the early hours of delivery. A special antiretroviral treatment should be administered to the baby, to the infant, and this guide talks about this one. These treatment, antiretroviral treatment for the prevention of perinatal treatment, and this is the number of cases that have been reported as transmission from mother to infant. It seems like there is a reducing trend when it comes to transmission from mother to baby. This is promising. HIV testing is so much important, especially anonymous HIV testing at no cost is so much important. We have mandatory testing in Turkey for blood and organ donors, registered sex workers, and also there is another kind of mandatory testing for applicants to voluntary counseling, applications for applicants for perimarital counseling, and personal applications to medical institutions after suspicious acts, and tests conducted before surgical procedures. The thing is, we have voluntary counseling and testing centers that we have to be proud of in Turkey. This is an important step in Turkey. Turkey has been doing some 10 million tests each year annually, but a big majority of these tests are conducted at the hospital setting before the surgical interventions. And there is only one case detected with HIV out of 25 to 30,000 cases in the hospitals. But when it comes to voluntary consulting and testing centers, the testing is done on a voluntary basis, and the rate of detection of HIV cases is a lot higher in these centers compared to the hospitals. The thing is, voluntary counseling and testing centers is established after negotiating with the local governments. The local government assigned a location for the center, and the center is established. Hacettepe University delivers training to the personnel of the center in the first place, and then people admitted to the center is receiving rapid tests of HIV, and test positivity may go down to 1% out of 200. So you can catch an HIV case out of 200 suspected cases. This is a great number, actually, compared to the numbers in the hospitals. And let me wrap up this way. Ministry of Health is collaborating with a lot of associations and institutions and delivering training activities, training sessions to the people to raise awareness, and also producing brochures and distributing brochures, trying to keep this topic on the agenda. And the thing is, this is hard work. This is absolutely hard work. And unfortunately, these activities have been hampered during the pandemic. Today, we have been gathered together to talk about refugees and migrants. And this is the distribution of HIV/AIDS cases by nationality. 84% of the cases in Turkey are Turkish citizens, and 16% are foreign nationals, and a small amount of people cases are people of unknown nationality. So the thing is, refugees and migrants are also included in this orange pie of the cake. But there are people, including regular migrants among those people that we do not know the exact numbers. I do not know the exact numbers. I think the next speakers will develop on this topic more extensively. As a person who has been engaged in this topic in the last 30 years, I can say that the government is providing opportunities of testing once people are admitted into the system. But the problem is whether everyone is admitted into the system or not. And the second problem is whether everyone can have access to the drugs or not. So we are going to elaborate on these topics today. You know, if an HIV case found a physician for himself or herself, then he will not die. He will be treated in Turkey. But the problem is whether that person can find a physician, whether that person can have access to the healthcare system in Turkey or not. This is what we need to discuss today. Professor Dr. Selma Karabey will be elaborating on this topic. She has been working in the area of HIV. She is from the Department of Public Health. She is going to summarize the perspective of public health for us today. Can you see me? Can you hear me? Can you see my slides? Yes, we can. Thank you very much. Thank you very much, Serhat, for the very nice remarks during your presentation. In 1992, the first association to combat HIV was established in Turkey. And since 1992, we have worked in an organic collaboration with Serhat Ünal and all the people engaged in fighting HIV in Turkey since those years. And I have to admit that we now transferred the flag, the combating flag, to the associations, including Positive Living Associations, Red Umbrella, etc. Now they will take from where we left. I am a public health specialist, and as a public health specialist, I can provide a public health related perspective to this issue. And I believe this is the description of public health that we can use today. Global Public Health of Oxford textbook defines the public health as follows. The public health is a state of biological, physical, and mental well-being for all the members of the community, no matter what their gender, wealth, ethnicity, sexual orientation, country, and political views can be. So this is the contemporary definition of the public health as defined by the Oxford textbook of Global Public Health in 2015. Well, the public health is normally a complete well-being for all members of the community. But Roger details is elaborating on the discrimination, because if you do not elaborate on the description, if you do not talk about multiple dimensions of the health, then you may miss out one of the dimensions of this description. I think this description is so much, definition is so much important that we need to consider. And this is a scheme that I use very frequently. This is a graph that I use very frequently. It was developed in the beginning of 1992, 1990s actually. This graph was done by Rudolf Wilkorf, the famous German pathologue. This is actually the modernized version of the principles of this German scientist. You can see this cycle, which talks about the main determinants of health, because the health is determined by many factors, multiple factors. You can see these multiple factors from a bird eye view on the graph. The determinants of health may include many factors, especially members of the community, how they are impacted by the setting they live in, whether they are discriminated against, whether they're isolated, whether they're marginalized, whether the healthcare services are delivered to the people this way or that way, or some of the determinants of health, actually. In this respect, we need to talk about the social determinants of health. This approach of social determinants of health is assuming a great role in the entirety of the public health system today. 170 years ago, Virchow, this German scientist, mentioned this already, but we had to rediscover these social determinants of health. There is not only biomedical dimension to health, there is also biopsychosocial dimensions of health, including the social determinants of health. And in the last 20 years, WHO and many international organizations started to focus on the importance of social determinants of health. The social determinants of health, if there is a healthcare system in your country which is not considering the social determinants of health, then that healthcare system cannot make a proper planning for health.
Also know that some individuals in the community die earlier than the others because they develop more diseases. Please look at this chart from left to right, because these individuals encounter more risks and they get engaged in more risky behaviors because they do not have the powers or they have less opportunities to defend themselves against risky behaviors. So they can get less acceptance in the community, less respect in the community, and on the background you can find some factors on a more macro scale. Well, in public health, in fact, we call this approach the causes of causes approach. Well, in contemporary public health, in fact, we believe that we should be looking at all the public health issues with this approach, because when you cannot touch the root causes, when you do not take steps to deal with the root causes, unfortunately, you will always remain in a vicious circle. Well, I felt the necessity to make such an introduction because HIV/AIDS topic should be addressed within this framework, and this is the only way that you can overcome this issue. It doesn't have only a medical aspect. It doesn't have only a therapeutic aspect. However, as dear Serhat has just put it very well, so, there are also situations like discrimination, blaming and stigmatization. Unless we also cope with these issues, it means that we are always missing the major part of the iceberg, because there are some risky behaviors that can cause the spread of the disease, and we cannot eliminate these causes otherwise. Because when there is more tagging, labeling, and stigmatization in the community on a health condition, if the individuals with a condition are excluded in a community, then the people would like to speak less about that condition, and all the perceptions will be closed, and they will be inclined to ignore the condition, and then they will be ignorant about the risks and the behaviors and the actions, and all the risk perception will be lost. In conclusion, all these, in fact, will pave the way for health inequalities. And this is the most basic aim of public health, reducing inequalities in health. In fact, average life expectancy difference between the richest and the poorest in the world is 45 years. And in Africa, we know that there are many early deaths because of HIV/AIDS. So some figure from Nairobi, in fact, depending on the neighborhood, in fact, your life expectancy can be guessed, you see. But how should we and why should we deal with inequalities in health? Because it is possible to prevent if you can take rational steps, if you can take proper steps, then you can eliminate inequalities in health. You know, this UN has developed these Sustainable Development Goals, and it is also closely following and monitoring the progress in goals. There are 17 of them, and almost all of them are related to public health and health in general. And a reduction of inequalities, in fact, is directly related to goal number 10. And in fact, these are goals with either a direct or indirect contribution to our initiatives. As distinguished representative has just mentioned, if we want to leave no one behind, then yes, we need to change our perspective a little, and we need to be looking from a broader point of view. And this is how we should struggle with the problems. Well, let's look at the groups which are encountering the health inequalities the most. Of course, the individuals living with HIV/AIDS. And I have a major place in this ranking. In fact, I'm a public health specialist, but I really have some focus on this condition. So I am also always studying what kind of advocacy can be made. And I am an academician, and I always find some meaning in orienting my powers and opportunities and means to this topic. Maybe when we first started, we were not very aware of all the details. However, in years, we learned a lot from the activists working in this field, or from the individuals who are personally living with AIDS, HIV, or their relatives and the beloved. And in fact, that caused us change our way of handling the problems. For example, discrimination and stigmatization with HIV, AIDS. In fact, a pandemic, it arose, and it was just like a rock, a big rock ahead of us. And some groups, in fact, turned out to be scapegoats. Jonathan Dorn, and a legendary public health specialist. We lost him very early. In fact, he was the first director of global health program. So Jonathan used to say that, okay, these social signifiers, inequalities, stigmatization, discrimination, he touched upon all these topics, and he said that in the ghettos of New York, if you would like to give a contraceptive to a Black individual, then you need to first give him a future. You see, first the individuals need to find some meaning in life. They need to have and expect for a future. If they don't have these, then it will not be very realistic to guide those people to use condoms and contraceptives. Well, so many pieces of research nowadays show us that discrimination has direct and indirect impacts on health. It has a direct impact on health because a certain condition, a certain disease, infection, or behavior. So individuals with those can be directly exposed to violence because of alienation and, having no acceptance and recognition in the society and being exposed to violence all the time, that can bring about additional problems, substance use, suicide, depression. So all these are interlinked. And also we should say that there are more restrictions in accessing healthcare and social services. There's learned helplessness because people act with the assumption that I will be alienated, I will be treated badly, mistreated. That's why those people avoid. However, if we develop a different perspective, and if we can have some cooperation, and if we can cooperate with those who are directly in that field, then we can really achieve a lot. For example, there is a project in India, sexual workers, in fact, are here in this project. And in fact, the use of condoms increased to 90% from 1%. So if you are going to work in the field of AIDS, then in fact, we should be directly working with people who are most affected by this problem. We should be working with the activists. We should be working with the people who are in the field. So about right violations in Turkey, we know that the most important and major violations, in fact, happen to take place in health. Well, there are some reasons for this. For example, wrong and inadequate counseling and misinformation that can really affect the lives of these individuals. And there's also lack of access to various healthcare services. For example, we don't have the gloves and we cannot take you to surgery. Unfortunately, these happen. And this study was done with medical students. In fact, it is dated 2007, but this year this is done again, and I am really waiting for the results with curiosity. You see, this is about the 5th and 6th years in the medical schools, and from the results you can understand the prejudices of medical school students against HIV-infected individuals. However, we shouldn't be pessimistic because we know that education works. It works a lot. And this is also shown by certain research results. Even some training of 1 hour or 2 hours, if that can be given to the medical students by the activists or the people from the field, they can create miracles. And they can significantly reduce the prejudices, and it can change the attitudes. Last but not least, so in the public health field, I in fact try to do my best in order to raise awareness, and I would like to, I always try to make a call to my colleagues in this. For example, groups with special needs, their health issues have to be made visible. This is quite crucial. And also, it is necessary to do advocacy to improve the services aimed at these groups. And let me repeat, we have to do all these together. In fact, we shouldn't be planning for the individuals, but we should be planning with the individuals. And also in all the educational programs and curricula, in fact, pre-graduation, post-graduation, in all the curricula, we should spare some space for these topics. And I know that some of my doctorate students are also watching this webinar. Let me give some messages to them. the individuals with special needs, in fact, is a special topic, a special course that we have in the public health department. In fact, we pay field visits. We visit certain associations, for example, Positive Living Association. We try to grow some sensitivity in the young people about this topic, and we would like to give them the idea. And in conclusion, I would like to say that not prejudice or discrimination, but safe sex and precautions protect from HIV and AIDS. Well, we cannot shut our eyes, ears, or mouth. We should see, we should hear, we should talk. I think during the last decade or 1.5 decades, we started speaking less of sexuality, safe sex. In fact, these topics are evaporating. And yes, in the past, those topics had to, in fact, used to have some space, but now they almost disappeared from our curricula. And only if we can talk about these topics, only if we can have discussions about this, only if we can install systems which will enable discussions on these topics, we can overcome these problems. Thank you very much. For the time being, I would like to stop here. If there will be any questions, I will try to elaborate on the topic later on. Thank you. Professor Selma, thank you very much. Thanks a lot. And without losing any time, I would like to give the floor to our next speaker, Mr. Canberk Harmancı from Positive Living Association. He will go into the deeper lengths of the topic and will give his perspective to us. Thank you very much. Let me open my presentation first. So speaking after two doyens, professors of the field, yes, I feel very nervous, but anyway, I will try my best. I think now on the screen you can properly see my presentation, yes. Let me start by talking about, very briefly, the Key Refugee Groups Project. It is implemented by UNFPA, Positive Living Association, and Red Umbrella Sexual Health and Human Rights Association. And it is founded by European Union Humanitarian Aid. It has been implemented since 2018. In the scope of this project, LGBTI refugees living with HIV, and the refugees which can encounter HIV are provided with protection services. 6 different cities, 7 service units. 2 of them are located in Istanbul, Yalova, Denizli, Eskişehir, Ankara, Mersin, and other provinces where 1 service unit each is established. These are the basic protection services provided to the key refugee groups: psychosocial support, legal counseling, information sharing, awareness raising activities, post-HIV testing counseling, peer counseling, and GBV case management. We have expert service providers who provide these services. In the first part of the presentation, we'll talk about the protection sector and health sector and their intersection, and also HIV in the crossroad of protection and health sectors. Because when we start talking about HIV, normally, or mostly, we talk about the health aspect as if only it's a problem for the people working in the health sector or healthcare professionals, or people just think that HIV just interests people working in the infectious diseases departments of the hospitals. However, because of social perceptions, HIV has to be studied in an interdisciplinary way. It has to be responded in an interdisciplinary way. This is applicable for both the host communities and the migrants and refugees. Well, here, what I'm trying to explain is that providing access to diagnostic services and therapeutic services, or access to medication, this is not all, because there's some time spent until accessing the treatment, and there are certain factors that increase the protection risk. We have to be managing those risks, and we have to be doing all these actions, taking all these actions at the crossroad of protection and health sectors for successful case management. Very quickly, I would like to talk about factors that increase protection risks. Well, first of all, of course, non-registration, because in Turkey, a foreign with any kind of status In order for him or her to access health services, first that individual has to be registered. If there is no registration, the individuals cannot benefit from the health services. As Professor Serhat mentioned, the lack of treatment in fact brings about death in those cases. Another factor is violence. Well, here violence can be categorized into two. Here, the first one is sexual violence. So for the victims of sexual violence in the attempts there in the scope of clinical management of rape, there has to be preventive treatment, and because after sexual violence, the individuals can be exposed to HIV. I'll be talking about this later more. And the second type of violence, in fact, happens after HIV is diagnosed and discovered. That it can be physical or psychological violence coming from the acquaintances. In fact, in the counseling that we give, we know that violence of this kind is very common. And in fact, a disclosure can be used in the communities. Another increasing factor is discrimination. If I'm not wrong, in 2017, Hacettepe University and Başkent University did some awareness research, and there was a very striking result here. 75% of the community, in fact, didn't have any information about HIV infection. Well, I don't say that little information or less than what is needed. I want to repeat, 75% of the community do not have any information about HIV infection at all. This is lack of information or misinformation that can bring about alienation, discrimination, or stigmatization against individuals living with HIV. So this is discrimination, but this discriminating behavior can prevent individuals from benefiting from diagnostic and therapeutic services. Another factor that increases protection risks is employment. Well, HIV if it can bring about unemployment if this condition is found out by the employers. And also there may be a period of 8 to 10 years without any findings, and there should be no loss of work or etc. But lack of knowledge, in fact, comes with or brings about discrimination, and it then ends up with unemployment. And because of non-registration, if there is no access to treatment, if the HIV infection is very advanced, then individuals may suffer from loss of workforce, and until the treatment in the AIDS period is complete, then those individuals may have to be excluded from employment, and that exclusion from employment can cause poverty. Poverty is an important factor. It's an important factor that increases the protection risks. HIV treatment is provided for the registered individuals. It is free of charge. It may depend on the status, but remaining in treatment and having a healthy life, leading a healthy life, having a high life quality depends on certain means. There should be no poverty for this. For example, HIV treatment can be given in tertiary health facilities, but not all of them can be providing this kind of treatment. Speaking for specifically the migrants and the refugees. So the refugees living in certain cities and infected by HIV have to move to a different city for the treatment. And that relocation may be for a certain number of days or longer, and it means that those individuals should have certain economic means in order to travel, in order to stay in that new location. And because of poverty access to treatment can not be possible or can be interrupted. And destitution of social support is another factor that adds to the protection risks. And in fact, because of our lack of knowledge, or regardless of how much we know in the community that we live, because of this discrimination seeds that are implanted in our minds, then diagnosis can come with some trauma or a post-trauma stress disorder. And if you add to this picture the violation of rights, the psychosocial well-being can be very negatively affected. Well, also think about exposure to discrimination, social isolation, fear of violence. And if the individuals cannot get support from the social surrounding, and psychosocial well-being will be further reduced, and that will further add to the protection risks. Now, let me talk about how the migrants and refugees living in Turkey can access treatment. I will have separate slides. First of all, we'll talk about the status of temporary protection. So individuals coming from Syria to Turkey, so individuals of Syrian nationality. Within the scope of universal health coverage, those individuals can go to a tertiary hospital in their own province, and they can access treatment on free of charge basis in public institutions, or if there's any voluntary counseling and test center, they can also access the diagnostic tests free of charge. If not available, then those individuals should get the traveling permit, and regularly they should go to a province where follow-up and treatment services can be provided. If the status is international protection or international protection application, then I think it was in 2019, December, there was an amendment to the law on protection of foreigners, law on foreigners and international protection. There's access to universal health coverage for the first year. After the first year, the beneficiaries are wanted to have their own insurance, but for HIV, you know, the private insurances will not cover the treatment. What should be done here? In fact, 1 year after the application, when the universal health coverage provision is closed, and if that diagnosis came after that, then the individuals should apply to the provincial directors of migration management, and then they should ask for their universal health coverage provisions to remain open, and they should be providing this certain reports. If, or in the case of foreigners who are in Turkey with a residence permit, then the picture is more complicated here. First, there is the general health insurance for foreigners. In order to apply for this, and if those individuals have a residence permit, then in fact they can apply 1 year after acquiring their residence permit. Then the Social Security institution wants the individuals to prove that they got the infection, in fact, before the general health insurance. In fact, if the individual came to Turkey with the infections, it cannot benefit from the insurance. If the diagnosis was made in Turkey, but if that individual cannot evidence, cannot prove that the if HIV diagnosis is established after this application, then it can be covered as part of the respective health insurance. However, there is the right to apply to the labor code for the precautionary measures. There is some difference regarding the for the students. So those students who reside in Turkey, in fact, must apply for the general health insurance in 3 months after enrolling in a school. So they have 3 months. If they apply in 3 months, in fact, they can access the health services free of charge under the general health insurance. But Social Security institution will need to know that infection was caught in Turkey after the provision again. So it requires this evidence. If that evidence cannot be provided, or if the result is a rejection, again, the competent court will be the labor court. One can apply to the labor court for the precautionary measures or the cancellation of the decision of the Social Security institution. There are some important points. In order to keep the infection under control and slow down the spread, then anyone diagnosed has to be accessing the treatment as soon as possible, because HIV treatment, in fact, eliminates the spread of virus between the partners. So in prevention, in fact, we always emphasize that once diagnosed, the individuals should be accessing treatment, and it is not enough. Those individuals should remain on treatment regularly. So all the legislation, in fact, should be interpreted in a way to provide access to treatment in order to protect individual health and public health for those who reside in Turkey under legal circumstances. In the light of this information, as Professor Serhat, in fact, has shown, we know the control program. In fact, there's a key sentence that was written by Mr. Minister in the preamble. He says that in fact, all these works are performed and this control program is prepared so that each individual in Turkey can access the services equally. So when we are rendering the services, we make our plans accordingly, so that the people in Turkey, they should be accessing the treatment free of charge. I think this is how we should interpret the legislation. This is our responsibility. So people who are in Turkey in a non-registered way without a status, their vulnerabilities should be taught, should be taken into consideration so that they can get diagnosed and treated. GBV cases. And now I would like to talk about some preventive treatment here. Well, my key sentence is that HIV is a preventable infection, and there are preventive methods and medical methods. So pre-exposure and post-exposure medical methods are the two categories. And here, for GBV victims, I would like to talk about the post-exposure measures. There is a golden period, 72 hours for HIV prevention, and we can access and reach out many individuals within that duration. In Turkey, in 72 hours after GBV, if we can reach the counseling, then we should be able to talk about the HIV infection and the preventive PEP treatment to that individual, and also the law enforcement officers, the physician giving the forensic examination. Everyone should be informed. There is not a proper flow chart for managing the rape, and this information can be missed in many steps. And as of 2011 in Turkey, in fact, preventive treatment, in fact, is provided free of charge. It should be started in 72 hours. And this kind of treatment, in fact, is preventing the HIV virus from getting attached to the individual. Well, but I should say not only the victims, but the law enforcement officers, the judicial authorities, everyone has to be informed properly. If the access cannot be provided on free of charge basis, then UNFPA is providing a kit. So in our Key Refugee Groups service units, we have the PEP kits. So because of non-registration or any other reasons, if the individual cannot access the PEP, then they should contact our service units, and we can make sure that PEP is provided to the individuals who need it. This is important. In order for PEP to be provided, one should not be looking for the perpetrator. Maybe a perpetrator is not arrested, is not known, or maybe the test was not conducted during the judicial interviews of the perpetrator. Because of all this, we can miss the crucial 72-hour window of opportunity. So the perpetrator itself and HIV status of the perpetrator should not be important. The beneficiaries should be accessing this kind of treatment. Well, Professor Serhat mentioned about this in his presentation. HIV infection should not be thought by stigmatizing or criminalizing a certain segment of the society. So trans, gender, or heterosexual, homosexual, anyone can be affected and infected by HIV. So the LGBT sex workers should not be marginalized in service provision or prioritization. We have just seen the data of the Ministry of Health. So the majority of people living with HIV are heterosexual, cisgender individuals. So even if we are not working directly with the key refugee groups, all the service receivers in the age group of 18 to 45, in fact, should be informed about HIV, and they should be guided to get a test at least once, because the faster the people in fact get tested and treated, then the better results will be obtained. You remember the graph that was shown by Professor Serhat. The ratios will be reduced if we are faster, but if equal access to services cannot be provided, unfortunately the ratios in that graph will go higher and higher in the upcoming years. Maybe the individuals will not appear before you with an acute need regarding sexual and reproductive health. But once again, I have to underline that for individual and public health preservation, all our service receivers, service users should be given HIV awareness. So all the stakeholders working in protection sector, I mean, the organizations and the individuals working in the organizations should have the awareness themselves. They should have the basic knowledge so that they can quickly manage the cases. I would like to thank you very much. I think I haven't exceeded my time. So it's a pleasure to speak before you. You see our refugee support line. It is available 24/7. So it provides psychosocial support, legal counseling, HIV counseling, information about the service, and supporting access to services. Well, we can disseminate this contact. So if there's any doubt about HIV, if they would like to learn anything about HIV, you can easily refer those individuals to our support line. And also protective and preventive materials can be provided free of charge. Just you can refer your service users to us, to this support line. Thank you very much for your kind attention. Thank you very much. Canberk, you covered all the aspects of the problem, and you also offered the available solutions. Thank you. Now, very quickly, I'd like to give the floor to Hatice Hilal Varan, Key Refugee Groups Istanbul Service Unit. I know that in Istanbul there are 2 service units. You are working in one of them, dear Hatice. So what you are doing? Hello, thank you, Professor. Now I am putting my presentation on the screen for you. I think it's okay now. Yes, it is okay. As Canberk has mentioned, we're implementing this project, the Key Refugee Groups Project. EU Humanitarian Aid Operation is financing. UNFPA, Red Umbrella Association, and Positive Living Association are executing this project. We have certain services under this project, psychosocial support mechanisms and case management process. In fact, are designed according to the special needs of our beneficiaries. Legal counseling, psychosocial support, case management, information sharing are the basic services that we provide. Today, I would like to share 2 real case management examples with you. In fact, these examples are directly from the Key Refugee Groups Project. These are the cases that we manage. First, some background information about this case. Female beneficiary was reached to our refugee support line, has stated that she was 38-week pregnant, in labor, and was sitting on a sidewalk and was waiting for some help, and she requested our support, and immediately we learned the location of the beneficiary, and then we went to her location together with a translator. We had to do the planning very quickly. So I will be talking about a process, but it took just 3 or 4 days. So in a very short period of time, we had to manage some very sensitive dynamics. We were on the way to the hospital, and also we were trying to get the basic information and credentials of the beneficiary. And here you see the basic information about the beneficiary. She is 37 years old, national of Dominican Republic. She came to Turkey in 2015. And her partner was in jail in Turkey because he got involved in a crime. And she also, because of pregnancy, in fact, she wouldn't be deported. And however, she got diagnosed with HIV in the hospital, which she visited because of her pregnancy test. However, the hospital didn't admit the beneficiary in the hospital because of wrong registration. You see the protection risks, and these are the factors that we had to deal with concurrently. So unregistered status and administrative decision of cannot be deported, living with HIV and being unable to access treatment. Deterioration of well-being due to social exclusion and poverty related to HIV status. Status of administrative detention, deportation due to posing a threat to public health and protection in accordance with the law on foreigners and international protection clause number 54. That was a risk for future. Advanced pregnancy, risk of HIV infection for the baby. being a single parent and single woman in Turkey, no social support at all, language barrier. She could only speak English and Spanish. And because of language barrier, she was extremely challenging in accessing the resources and services, and she had low awareness level. So she herself didn't have information about HIV, and she didn't know about the social resources available for her in Turkey, and also regarding safe parenting and pregnancy process, she didn't have sufficient knowledge. Risk of HIV infection for the baby. In fact, the professor has already talked about this, but I would like to give some additional information here. The transmission of HIV from mother to baby, in fact, basically happens during pregnancy, childbirth, or through breastfeeding. Some measures can be taken. Treatment of the mother during pregnancy, delivering the baby with C-section if possible. The baby will be exposed to less blood, and also no breastfeeding. And if possible, in the first 24 hours, the baby should be given PEP, post-exposure preventive treatment. That was already mentioned by Canberk. So we did the first interview, we identified the protection risks, and then we had to assess the needs, and also we had to discover the demands and the priorities of the beneficiary. We created the response plan. First, we decided that we had to plan the delivery immediately, because the labor already had started. Emergency delivery planning, in fact, it means you have to decide on the hospital to go to, what is the mode of transportation, bus, taxi, ambulance, who is going to accompany the mother, and who else can provide some support in the hospital. So there are many layers. In fact, there are many steps to be taken into consideration here in this planning. Then, supposing that the labor took place, you have to think about other steps, for example, identification, empowering activities. If necessary, legal, psychosocial, and other protection services should be provided and available. And also there will be monitoring, and because we have to make sure that if these services were accessible by our beneficiaries, how much their needs were covered. If that was not possible, from which step should be restart. So these are all the steps that we take into consideration when we do this kind of planning. Intervention for access to health services before the birth. Ensure admittance of the beneficiary to the hospital in order to resolve the emergency health needs. This is just a sentence, but it took almost 2 days of ours, and we contacted an unlimited number of institutions. There were 3 hospitals we contacted, 1 private and 2 public hospitals. So physically, we visited these 3 hospitals, and the hospitals can offer various excuses in order not to admit the beneficiaries. One was about the risk of HIV infection for the personnel. One excuse was that the services were not available for the Dominican nationals. Another excuse was that individuals with HIV could not be operated or could not go under procedures, or they didn't have a newborn or infant unit in their hospitals. Just some excuses that the hospitals offered to us in order not to admit the patient. But then we had to use our personal relations, advocacy activities, etc. So we made the patient admitted in the hospital, but that was not over. Nurses, other healthcare professionals, even the teller in the hospital, we had to contact and talk to everyone so that we would be sure about the confidentiality and the mechanisms would be used in order to cover the needs. And the beneficiary didn't have an ID. And the doctors were concerned that they had to notify to the police. This is what they thought. And also she was living with some infectious disease and that could be a threat to public health. And they thought that they should notify this to the police because of this threat. And that was about information and awareness raising. We raised awareness about these topics. We made sure that the patient was admitted to the hospital. It was an emergency case, but the woman didn't have an ID card. So a paid patient file is opened. It means that all the costs will be charged. And in fact, then the pressure comes from the hospital. Will the costs be paid, who will be paying it, etc. And we had some nice cooperation here. In fact, one NGO supported us to cover the delivery, the labor costs. And also, you know, we had a priority, the PEP to be accessible for the baby after the birth. And in the hospital, there was not ready prophylaxis for the baby. This is what we found out. And we called the provincial health directorate and we made our request. And the answer we got was that, okay, there was COVID at the time. They totally focused on countering COVID-19. So the individual had to get the PEP itself. The beneficiary had to get the PEP itself. And the personnel just made some donations. In fact, they economically supported the beneficiary. The drugs, medicines, needed vitamins were covered with this donation. In fact, the public and the NGO, in fact, collaborated. So the beneficiary was a single woman. There was no accompanying individuals for her in the hospital. So in and out of the hospital, she needed some immaterial support. And also her needs had to be covered physically too. And also she had to overcome the language barrier and her access to services had to be facilitated. That's why we made one interpreter ready there continuously. And then the delivery happened slightly earlier than expected. In fact, when we had done the emergency labor planning, in fact, we also had got the number of the taxi station that is closest to the house, making the women memorize the home address. When the labor started, she told that she would not be able to use any mass transit vehicles. We just mobilized a taxi. So the mother was taken from house and brought to the hospital. Again, there was one protection officer and translator ready there. And when the baby was born, the PEP process was initiated immediately. Again, a pediatric infection physician was contacted for prophylaxis. A prescription was obtained from the physician. So the medication, especially for the babies, is not available in every hospital and every pharmacy. So we had to decide on the pharmacy in advance. We contacted them. We ordered the PEP to be brought from the pharmaceutical warehouse, and the baby got the PEP in a timely manner. So all the needs and all the details like documentation and signatures. In fact, we were always in contact with the hospital, the nurse, and the social worker. After the discharge, not everything was finished because socioeconomically and psychosocially, we had to empower the mother and the baby. So the hospital expenses were a huge burden. And in future, other protection services could be prevented by this burden, because when you have an unpaid debt to hospital before you access other services. First, you have to cover the outstanding debt. This is the system. And we lifted this burden with the support of an NGO. We got mother and baby kit from a municipality. Since the mother was HIV positive, she couldn't breastfeed, and the baby formula is quite expensive, and also the diapers. And we got baby food support, ration support from municipalities, and another NGO covered the rent for that month. Had some interventions to reduce the protection risks. In addition, the report of word was received from the hospital. The registration process was initiated. Vaccination calendar of the baby was explained to the beneficiary. And since the hospital and the place of residence was far away from one another, and the mother would not be able to take the baby to the hospital by herself, the closest migrant health center information was provided to the mother, and interpretation and accompanying support was provided each and every time. Then came the identification processes. UNFPA Women's Health Counseling Center provided postnatal care, women's health trainings, baby care, and safe parenting trainings. And from the service unit, the mother got a regular psychological support. You know, after the administrative decision, what could happen, what would be the basic risks about her and the baby, and the legal counseling was provided to provide all this information, and other personal counseling provided as well. So shortly, I can say that in social, legal, health aspects, many sensitivities and vulnerabilities and protection risks were there for this beneficiary, but we acted very swiftly together with the beneficiary, and we took into consideration the priorities of the beneficiary. We had to do the case management planning accordingly. In such planning, it's critical to act in coordination and timely. If you act timely and in coordination, things will be slightly easier. In conclusion, in the test conducted 6 months after the birth, the baby was HIV negative and had no other health issues, and there was positive changes in the physical and mental health of the mother. Another case example, the beneficiary presented to the service unit directly and was diagnosed with HIV about 6 months ago, but was not able to access treatment and asked for support. We did the first interview with the beneficiary. The beneficiary was a 26-year-old Syrian, cisgender, homosexual man. In 2015, because of his sexual orientation, he was exposed to physical, verbal, psychological violence, and he fled Syria and arrived in Turkey. Since 2015, he lived in Istanbul under temporary protection status. In 2019, he started working with a work permit, and his insurance was activated. In 2020, he was diagnosed with HIV in a public hospital and was unable to receive medicine from the pharmacy where he had gone to start his treatment. This is what he reported to us. So let's compare this to the previous case. And in his access to treatment, there shouldn't be any barriers. However, he was rejected by the pharmacy. Just like we do all the time, first we started by understanding the protection risks and sensitivities. Living with HIV and being unable to access treatment, deterioration of well-being of the beneficiary due to social exclusion related to HIV status and poverty. Because that person, retracted from the employment market, and So according to the Law on Foreigners and International Protection, Article 54, the status of administrative detention or deportation due to posing a threat to public health. Another risk, because of the HIV diagnosis, the beneficiary was traumatized and there were significant symptoms of post-traumatic stress disorder, low awareness level, and language barrier. These were discovered in the first interview. And the initial steps that we took, interview with the pharmacy. In that interview, the pharmacy responded that the individual has to go to the social security institution and had to get some health provision to show that he can get the medication. And we told that, okay, he got the work permit in 2019 and there could be no problem with the provision. However, the pharmacy wanted to see that paper. And the beneficiary went to the social security institution and wrote its petition. And it was in the petition, he said that he, after introducing himself, he was asking for the health service provision. In reasonable time, we didn't get a response. A second petition was written, and we said that according to law number 5510, according to Article 64, I got diagnosed after the beginning of my insurance, and also according to the attachment of the surveillance regulation, his condition, HIV condition, was eligible. Also, according to Article 60, so HIV infected individuals would not be excluded and would be eligible to have access to treatment in a timely manner. We compiled all this information and gave it to the Social Security institution. There was no response to the first petition, and in the second, after the second petition, we got a response, both a verbal response and a written response. It said, the individual has to have an HIV negative result obtained in Turkey. And in quotation, it cannot be determined if the individual brought this infection from his own country. That's why the treatment expenses would not be covered by the Social Security institution. That was the response that we got. And then we wanted a lawyer to be appointed from the Bar Association. From the Legal Aid Bureau, a lawyer was appointed. And to the Labor Court, we applied for precautionary measures and cancellation of the decision. During the litigation process and exchange of petitions and the responses, we didn't leave the beneficiary alone. Socially, legally, we provided him with some post-test counseling service, and we told him about his rights. We provided psycho-education regarding sexual health and reproductive health. Peer counseling was provided, and legal counseling was provided regarding work, life, and rights. In conclusion, the litigation process was concluded with a measure order. The treatment was started, so the litigation ended in favor of the beneficiary. About 1.5 years after the HIV diagnosis, the treatment was initiated. In summary, we see every individual as unique, and we organize our case management processes accordingly. Together with the beneficiary, we try to embrace all the sensitivities, and in legal and social framework, we try to take the best actions that we can, and we try to make the best interventions that we can. We have a basic motto here: rights-based work. So since an individual is a human being, we have to work on the basis of human rights and rights advocacy. But the public sector or the NGOs cannot achieve all of these alone. if the public and the civil society organizations can stay at the same plane, and if there is collaboration and coordination, then success can be possible. Good practices can be multiplied with this kind of collaboration and coordination only. So I hope we will have more of good results. Thank you. Over to you. Well, thank you. These were good examples. Now I would like to continue with the Q&A session. I'm the moderator. I would like to ask the first question myself. That was a nice talk, but I understand that the system is not very settled. So how much of the needs can you
olarak girişi her ne oradaki
the decision of the personnel who is making the entry into the system, and it is very difficult to revert this entry. It depends on the code that the personnel is using when making the entry into the system. That will define the whole management process. So any emergent delivery, if it doesn't appear emergent enough, then different codes are used, and then the beneficiary is shown as a tourist patient, and then it is charged. Esra İrem Yılmaz is asking. She says that, as far as I know, in Africa, HIV positive mothers can breastfeed their babies. And are there any studies about breastfeeding methods without HIV transmission? Is there anyone who would like to answer? Otherwise, I will answer. Yes, you should answer. Yes, this is benefit or damage balance. In certain cases or countries, if there is no breastfeeding, then the baby will starve. This is, in fact, depending on the load. If there is proper medication and the viral load is managed, then there is nothing wrong. There is nothing wrong with breastfeeding. In fact, breastfeeding is breastfeeding. It doesn't matter if it is direct feeding from the breast or milking. It is still breastfeeding, but it depends on proper medication. If the case is managed good, then breastfeeding can be possible, but it's about, the chance of survival. If there are any other options for feeding the child, then those methods should be preferred. Shervan Beyazet. Does access to PrEP differ between adults, babies, and children? And if the baby is HIV infected, how is the medication used? Okay, by PrEP access, I think he refers to rape and also the prophylaxis and also the babies born of HIV positive mothers. Let me answer. After the birth, the medication provided to the newborn, in fact, are pediatric medicines of standard use. Yes, syrups, oral, yes. In fact, Hilal mentioned some important detail in her presentation. The Director General of Public Health have about 6-7 warehouses in Turkey where they keep a stock of those medicines. And also the provincial directors keep them available in certain centers so that they can be made available in a very limited time in the neighboring cities. Yes, we can make the request for the migrants and refugees, but the procedures differ. So first there is a need for prescription, and then it will go to the provincial directorate of health. And in last case, that was the COVID, it was an extraordinary situation. After the birth, if the newborn is diagnosed positive, then with the pediatric medicines, the treatment is started. And however, registration is again important. If there's registration, there is free of charge access to the pediatric medicines. Thank you. Ahmet İnkaya. Syrian migrants living with HIV. Is there any barrier before them to apply to the university hospitals? But Syrians have the ID cards, but is there any difference in accessing the university hospital and the state hospital? Okay, if the individual is registered, if there is temporary ID card, there is no barrier, but there are certain steps that person should go into the referral chain. So from the secondary facility, there should be a referral to the tertiary hospital. Otherwise, the treatment in the university hospital cannot be covered. Currently, in the secondary facilities, there is no treatment. If it is a university hospital, there has to be referral from the secondary facilities. Gamze Karadağ's question. She thanks you, Professor Selma, and she is thankful because you emphasize the sensitivities in the field. And there are many thanks to you all. Gökhan from UNFPA. Foreign students or those with a residence permit. Sorry, I mixed up all the questions. I go back to the original question coming from Gökhan. This is for Professor Selma. He thanks Professor Selma for the nice presentation. He asks, in fact, we are aiming at a globe free of HIV, but looking from the lens of public health, how do you position the multi-sector and multi-stakeholder approach? The answer will take a second lecture. Yes, I will try to be brief as much as possible. Okay. We think in various layers as public health people. So when I look from the first line, the improvement of health. So this is about pre-infection and the prevention measures. I can easily think about the Ministry of Health, Ministry of Education, international and national non-governmental organizations. So they need to be in close cooperation if you are asking about multi-sector, multi-stakeholder approach. So it is vital that necessary education and training should be provided. So sexual health, sexuality, they have to be talked about. So there should be some enabling environment to talk about these. Otherwise, we cannot overcome these problems. Sexual health and safe sex. In this context, there should be education about countering discrimination. And also this should start at early ages. About secondary protection, so this is about early diagnosis of the infection and early treatment. Again, there is need for intersectoral cooperation. So dear Serhat, you showed that slide. Şişli municipality has a center, and the positivity ratio among the applicants is very high, 6%. So it means that the municipalities have a nice outreach. They can easily bond with the communities and the individuals concerned. So municipalities, Ministry of Health, and social services should be in close cooperation for comprehensive management of this process. This is crucial. As for the tertiary protection, so this is after the infection, and what can be done after that for minimizing the damage. In fact, we all heard this nice examples from Hilal, but we know it very well that projects are such structures with a certain deadline. For example, Hilal is employed by a project. When the project is over, the service may not continue, unfortunately. So those should be integrated into a system. Projects are done to set good examples and also to integrate them into the main system. So all these good examples should be made a part of the system. Health ministry, social services, agencies, municipalities, in fact, are the priority entities to collaborate. Thank you. Azize Tiryakioğlu's question. So for HIV treatment, when a litigation is started for precautionary measures, how is the conclusion of the litigation for the foreign students and those with residential permit? Yes, there are some positive examples about the conclusion of litigation. For example, some individuals who got Turkish citizenship through marriage and in fact restarted their treatment. And in fact, but until that, with the precautionary measure order, in fact, they were benefiting from the treatment in the meantime. Yes, maybe not many, but there are such positive results. Rather than legal status, in fact, the registration of the individual and the beginning date of the insurance are important. And also whether the HIV diagnosis was made before or after the insurance. These are giving us a strong hand in terms of advocacy. Sibel Türkmen. So, foreigners with a tourist ID, in order to have free of charge delivery, can they contact any units in Eskişehir? For example, NGOs, private hospitals. Do you have any address in Eskişehir? Well, yes, we have a support line. This is our basic communication line. Yes, in 7 provinces we have service units, but in fact, those service centers, in fact, provide services to the whole country. So all 81 provinces are distributed to all 7 centers. So any case detected in Turkey or anyone in need can reach us through our support line. We will refer the applicants to the relevant service unit and the process will be initiated. Özge Yanbolluoğlu asked the same question for Hatay, but you already answered. If there is a potential beneficiary living in Hatay, do you suggest that they should use the same support line? Yes. No matter where they are located in Turkey, they can use the same support line. All the questions are answered except one last minute question from Gülden Ersuz. Yes, this will actually be the last question. We have exceeded 2 hours. Thank you for the detailed question. There are certain medications provided to the victims of sexual violence in the scope of the project, but these are lopinavir, Vironavir, and similar combinations, but they should be updated. Can they? Well, this is not something I can answer, but let me give my response. These kits, in fact, are prepared globally by the UN and dispatched to the relevant service units. But you know, new kits are procured. So there's an ongoing process about this. Maybe in future that will be possible. Yes. The prescription is not made on the basis of active substances in Turkey, but mostly these are combinations. Yes, Gülden, let me respond. I am not going to give the specific names of the drugs. In case of rape, you will just administer this for once, not for a short time. She's also referring to antibiotics, but we don't know which one. But anyway, we got your message. Thank you. Before I close, I would like to ask you if you have any last sentence to utter. Okay, the messages are given. Let me thank you on behalf of you all. Sincerely, we were so blinded by Corona that we forgot some diseases. I don't say that, okay, coronary artery, cardiac diseases, yes, they're also forgotten and they have to be looked at again. But HIV is really forgotten. And also, Hilal said it very clearly. There was one response from the hospital there, sorry, the directorate, there is Corona now, we cannot help you. You see, this is the picture. Jump back. I have one more question for you, one last question. Can the physicians use that hotline? Because recently we received an expert witness opinion. So they required some evidence about being HIV positive after entrance into Turkey. So we have some gaps in information. Yes, we can call you directly. We can call Hilal directly. But when we have gaps in our knowledge, how can we find information as a physician? Maybe we should have a phone number for the physicians. So migrants and refugees, they're a specific group, so information can be critical, but if we lack this information, service can be interrupted. Maybe we can advise something like this. Yes, of course. Our service units, in fact, meet the infectious diseases physicians because they would like to add them in their maps. And in November, we will have a national congress. I will be there, so we can have a chance to meet. And all the infectious diseases physicians across the country can be included in our communication network, and we will be sharing our contact numbers. Thank you. I would like to thank the funder, EU, the implementing agency, UNFPA, the two associations. Thank you for your participation. I would like to thank the audience as well for their kind attention. And I am closing this meeting with the last sentence. The broadcast will be recorded and will be accessible and remain on YouTube at the address of UNFPA Turkey. Thank you. Hope to see you in other events too. Take care. Thank you. It was very enjoyable for all of us. Serhat, thank you very much for the nice moderation.